And then finally, a reminder that closed captioning of this webinar is available within Zoom, and you can find it using the functions at the bottom of the screen. Next slide, please. So I am Carmen Masson. I'm a faculty member at the University of California, San Francisco, Department of Psychiatry and Behavioral Sciences. And the I-STARR project is co-led by Doctors Amy Miracle at the Public Health Institute and me. And the team also includes co-investigators Sarah Zemore and Lenny Jason, and biostatisticians Mina Subraman and Libo Lee, and communications director Diane Schmidt, and our team project coordinator Quinoja Capitini. Next slide, please. So the I-STARR project is supported by an amazing advisory board comprised of recovery housing leaders, treatment providers and payers, national policy advocates, and researchers and educators. And we will actually be hearing from one of our amazing board members today. Next slide, please. So let me tell you a little bit about our presenter, Dr. Quinn No. Dr. No leads research activities at the Hazelton Betty Ford Foundation as the executive director of the Butler Center for Research. She earned a double PhD in clinical psychology and women's studies at the University of Michigan in Ann Arbor, where she also completed postdoctoral research fellowships and subsequently held a position as an assistant professor in the Department of Emergency Medicine. Dr. No has conducted NIH grant-funded research on trauma and violence as they relate to substance use and substance use of current and emerging technologies in behavioral health research. She has authored more than 60 peer-reviewed scientific publications and several book chapters, and she regularly presents at local and national conferences. And she continues to dedicate her career to bringing research to practice in support of our most vulnerable populations. So without further delay, let's turn the presentation over to Dr. No to get things started on the topic of integrating recovery housing with substance use treatment. Next slide, please.
Thank you so much, Carmen. That was a lovely introduction. I appreciate that. And thank you all of you for joining me this afternoon. I think someone needs to go on mute. Okay. As I was saying, welcome everyone, and thanks for joining me today, this afternoon for this webinar. We'll be exploring how recovery housing can be integrated into substance use treatment, and talk about both during and after the clinical treatment process. And this approach is gaining traction as a way to support longer-term recovery and stability. I know I'm kind of preaching to the choir here in that regard, but I think it's really important to talk about how substance use treatment and recovery housing can be integrated. Next slide, please. Thank you. So today we'll be talking about recovery housing during and after treatment, and then I'll cover some key elements for connecting substance use treatment with recovery housing, and then talk about some benefits and some challenges. And I think today we're holding on questions until the end, but I'm hopeful that we'll have a pretty good chunk of time to talk about, to have more of a discussion around the integration of treatment and recovery. I think there's probably a lot of people with some good wisdom here as well. And so hopefully we'll be able to have a great discussion around that. Next slide. So the current approach generally, in terms of addiction treatment and recovery housing, is that they're really approached in a very separate way. So, which, you know, as an academic, when I moved from academia into the treatment side, it was it's hard for me to wrap my head around, and as a clinician, that these two pieces that really are so so connected in many ways are actually very separate in the industry. And so ideally, on the next slide, the hope is that they would be much more integrated. So they're not 100% overlapping, but to have more of a connection there and acknowledging the importance of recovery housing in an individual's journey through recovery is really important. So having both of them connected would be, I think, ideal. Next slide. So at Hazelden Betty Ford, we really look at recovery as a lifelong process. So you may start with addiction and you move through various levels of care, with different intensities and different needs, and really thinking about recovery housing as part of that. So not before or after, but really overlapping a lot of that, and with the idea that recovery is really a lifelong journey. So this is kind of a conceptual figure in terms of how we think about it. But on the next slide, what we see is that recovery is, in reality, very different. It is not linear. It is not simple. And the journey can be really, really different for different people. So people may step up or step down and step back up again when they're going through their treatment. They may start and stop and restart many times going through treatment. And recovery housing can be a real help in ensuring that individuals can maintain lifelong recovery. So on the next slide, I want to talk a little bit about the integration process. So during when we're integrating recovery housing during treatment, this allows for really good coordination of care between treatment providers and the housing programs. It also helps in terms of early identification of housing needs. We know that when there are other stressors that individuals have to face, including housing instability or challenges in transitioning back home after treatment, that can really impede an individual's progress in their recovery. And so having an integrated recovery housing approach during treatment can help to include housing planning in terms of treatment goals. And we know that transitioning from one situation to another and the stress that goes along with it can increase risk for return to use. So having that connection can be really important as people step through treatment. Next slide. After treatment, recovery housing can provide ideally a seamless transition from clinical care into outside of a clinical care setting. And so that again allows for a soft place to land in many instances where individuals are still working through some of their treatment goals and able to still be close to the clinical setting. After care, after treatment, there can also, recovery housing also offers the continued support through peer networks and case management, and having that connected to their previous treatment team when that recovery housing has been integrated into care. There's also time when individuals are in recovery housing, and especially when there has been a connection to the treatment and the treatment team, to practice some of the skills that have been learned in treatment in a supportive environment that might feel a little safer and a little more scaffolded than if they were to go straight back into their community. This also allows for monitoring and follow-up to ensure housing stability and to hopefully get connected with any other support services that are needed sooner rather than later. Next slide. And so when we think about the key elements of an integration model, it includes collaborative partnerships between treatment centers and housing providers. I think we could also include in there other types of social services. They're having a standardized referral process helps to ensure a smooth transition from treatment into housing and also into other supports that may be needed within the community. Another key element of integration is cross-training. So training for staff on housing resources and recovery support can really help with individuals moving out of treatment. And this is really all framed by the recovery-oriented systems of care. So when we think about recovery-oriented systems of care, these are systems that are person-centered. They're typically community-based, and where there's shared decision-making between providers and providers from different places, as well as the individual who's in recovery. And it really takes not a do for, but a do with model. So it's very collaborative in that way, really thinking and focusing on the strengths and resilience of the individual and their community as well, and ensuring services that are tailored to the unique needs of an individual with the hope that they can be in recovery in their communities as much as possible. Another key element to that integration model is data tracking and outcome measurement. So we need to make sure that what we're doing makes sense, is working, and is doing what we think that it's doing. So with that kind of framing and background, on the next slide, I can share a little bit about how Hazelden Betty Ford approaches this. And so with our framing of lifelong recovery, we do feel that recovery housing is an important part of recovery for individuals. So we actually have integrated recovery housing programs at 6 of our sites. And with the exception of our St. Paul sites, all sites also have residential programs. So they're really moving from a residential setting, oftentimes into a recovery housing setting on site. And so there's that access to medical staff and the previous treatment team. And so that happens in 4 states across the country at locations we have in Minnesota, Florida, Oregon, and California. St. Paul is the only site that is all outpatient, so it's not residential, but it is staffed by all certified peer support specialists. And they do have access to medical staff when it's needed. It's just not necessarily 24 hours the way that a residential site has. The other sites that don't necessarily require the certified peer support specialists have addiction techs that work within the recovery housing program. And it's a very collaborative treatment planning approach. So the staff of the recovery housing programs are very connected to the care team on the addiction treatment side. Next slide. So when individuals enter recovery housing at one of our sites, we introduce to them the 8 dimensions of wellness. And as part of that transition from residential treatment to outpatient IOP or partial hospitalization care, they receive a list of milestones that are based on the 8 dimensions of wellness. And so the team that works at the recovery housing in the recovery housing programs help patients to connect with whatever treatment team they've transitioned to. So if it's intensive outpatient treatment or partial hospitalization treatment, the recovery housing team works closely with them to ensure that the goals are aligned and that they're working together to meet the milestones that are recommended for transition out of recovery housing. So we really want to see our patients stable before they leave our recovery housing setting. So let's talk a little bit about the benefits of integration. So we see improved treatment retention and outcomes, reduced relapse rates, because that initial transition out of residential, there's a lot of support there. The enhanced social support and community reintegration is specifically a goal of our recovery housing program. And there's increased housing stability and independence because you have that time to work with your care team and with the recovery housing program staff to ensure that the next step for you is one where you can really be successful in your recovery. Next slide. So some of the challenges that we face. So there are a lot of benefits, and I think for those of us who are clinicians, we see the importance of having recovery housing integrated into treatment, and also there are challenges to it. So the first challenge is the limited availability of recovery housing. So we don't have it at all of our sites. We do have it at the sites where there are residential programs, but there are likely sites with outpatient care where our patients would also benefit from recovery housing. It's also difficult to staff. So having a recovery housing program, you have to staff. We staff 24/7, and so having it fully staffed with qualified individuals. I think everyone has experienced labor shortages of where it's been difficult to find qualified individuals, and so that's where Hazelden Betty Ford having an addiction graduate school has helped in some ways, as we're able to employ some of our students that come out of the graduate school. And then there are regulatory and licensing barriers. So for organizations that function nationally, being able to track from state to state the regulatory and licensing requirements that there are, the challenges that there are when you have a recovery housing program versus a substance use treatment program versus a mental health program. And some of our sites do all three of those. And so staying on top of that and ensuring that we're really meeting the requirements and ensuring the safety and best practices for our patients can be really challenging to track all of that. Next slide. So another challenge really is the need for culturally responsive and inclusive housing options. So we see that often in some of our residential programs where we have a fair number of Native American patients. And so wanting to ensure that cultural practices are really honored and supported as a part of that recovery journey is really important. And it can be really challenging because of the heterogeneity that there is among all of our populations. And so ensuring that everyone feels safe and supported. And, we don't always get it perfect, but we try really hard because we know it's an important piece of recovery and an important part of people feeling safe as they journey through their recovery. Coordination across systems and agencies. I think a lot of people and programs probably find challenges in this. So we can't be everything to everyone. We want to do what we do really well. And so who can we partner with and connect with and refer to, and then communicating for continuity of care, for case management purposes, all of those connections that need to be made for each and every individual. And it's, as you know, different for each and every individual. And so being able to tailor it to really ensure that each person has the best chance at success that they can with whatever support that we can provide. The biggest one, I think, for most of us is funding and sustainability concerns. The recovery housing, as you know, is often not reimbursed by insurance. And so how can we build a sustainable financial model? And, I think it's hard because when we're in a helping profession, it's sometimes hard to talk about the dollars. But if you're running a program, that's helping people, you have to talk about the dollars. And so really sitting down and thinking about the business side of things is really critically important to being able to do that. And, I mentioned that St. Paul is the only outpatient site with recovery housing, and it's actually the last site with recovery housing because we used to have recovery housing in Chicago. I'm not sure if our New York site ever had it. I don't think so. But St. Paul is the last outpatient site with recovery housing, simply because of the operational issues that we've run into with our strictly outpatient sites. So there are some real challenges to integrating recovery housing, even though clinically it makes a whole lot of sense in terms of the continuity of care, in terms of supporting individuals in their recovery. Those are all really critical pieces of it. But if we can't make them financially sustainable, then, we have to, we just have to find ways to do that. So those are the big challenges that we have run into. Next slide. So I want to take some time. I very intentionally kind of kept the information brief because I'd really love to talk about as a group experiences that you have all had, thoughts that you have around integrating treatment and recovery housing. Have you seen it done well before? Have you seen it not done well? What have been the challenges in that? So I would love for that. And if you have questions about more questions about how we integrate recovery housing in, I gave an overview of how we've standardized our recovery housing, but I'm happy to answer more questions around that as well. So do we have questions?
Yes, at this point, we're going to open things up to the audience members, and so that we can have a conversation with Dr. No. So folks can raise your hands within Zoom, or you can drop questions in the chat.
Cheryl, I think is
Yeah,
still
thank you. I was just trying to find the icon. Yeah, I had a couple questions and I joined a couple minutes late, so my apologies if I missed this. When you talk about integration, are you talking about same healthcare system, same providers, same payers, or are you talking about I know you're talking in part about that when you talk about Betty Ford Hazelden, but does what you say also apply to a treatment site and recovery in the community, and sort of increased integration may not be the right word, but increased collaboration between two different systems of care?
Yeah, that's a great point, Cheryl. And yes, I think also that. So I think that, as an example, because it's my experience, Hazelden can only have so many recovery housing beds. And so it's really hard to meet the need that's out there. So it requires good partnership with standalone recovery housing organizations. That just means, and we do that. We do, when we don't have space, we refer and find recovery housing for our patients who need it and want it. So I do think that that's critically important. And so there, it's really important to be able to communicate the appropriate information so that those individuals get the support that they need.
And so one of the things that you didn't mention, I don't think you mentioned, was whether in the housing community, there is feedback to the medical providers or to the therapists. If there is sort of an early indication that they're noticing in the housing center, in the recovery housing, that somebody is perhaps having difficulty being adherent with their treatment plan or showing red flags, whether or not there is communication back to those medical and psychological providers.
I think that that's a great point, and I think that's been a gap in the field for sure. So I think there is often communication when it's outside of the system, right? So it's easy within our own system to have that communication back and forth, and we do, and it's very natural. When you're partnering with outside systems, it's a lot harder, I think, to establish standard communication back and forth. So I think it's incredibly important, and I don't think that we as a field have worked that out as smoothly as we need to.
Thank you.
Mhm. Sorry, I see other hands up, but Carmen, you're on mute if you're saying.
I see other
Sorry.
hands too. Why don't you call people? Yeah.
Oh, okay.
I think Bono, who was waiting? I'm sorry.
Yeah, whoever, go ahead. John?
I have no,
Okay, Patrick,
it's
go ahead.
whatever. We have time. You did a great job putting together a concise presentation, so we have lots of time to talk. I appreciate that. Um, the question I had, so a little bit of background. So, I know that the research is for recovery housing specifically, those attached to treatment services, particularly in sort of the integrated model that you were talking about, tend to show better results than those that are just kind of standalone, right? They at least have some type of relationship. But I'm working with some folks here in New Mexico. I'm in Albuquerque to set up a NAR affiliate here. And I've been reaching out to people in the community doing recovery housing to talk about sort of the different recovery housing landscapes, stuff like that. And two different people independently were talking about like IOP services, right? They open up a treatment service and then they would see more dollar signs and so open up a sober living or, some type of recovery housing. And it's like, I mean, I see that, your organization and a lot of others come at it from this perspective of like, just can be really helpful, stuff like that. I'm just like, I'm puzzled over kind of what I've seen in the research and coming from that side. I haven't done a lot of sort of on the ground stuff. And so I was kind of surprised. I don't know if, I don't know. I don't know if there's a question there and maybe a discussion on like, how, how do we work in these recovery support services in a way that's kind of focused on the people in recovery, right? Versus, you know what I mean? Like I don't know, it's just it's a puzzle and it was concerning for me to hear. And this is, we've had some controversy, folks, particularly recruiting Native individuals to go out to like housing programs in Arizona that were, whatever. There was some, some dust ups over that kind of stuff. So we have, we've dealt with a whole host of issues here in New Mexico, and I'm just like, how do you even tell, right? Like if an organization is well-meaning, like you can't measure that. What do
Yeah.
we do? What do we do, Dr. No?
Well, and frankly, uh, people can have the best of intentions too, and also do things that are not necessarily in the best interest of their patients, right? So you can't always tell. And I think the way that you have to address that is with very clear metrics that on outcomes and the well-being of the individuals. So, and I know I'm speaking from a place of privilege in that not all organizations can have what we have here at Hazelden, which includes an entire outcomes team that measures outcomes on our patients. So we follow our patients for 12 months post-discharge. So, and that is a way where if there are individuals who are struggling early in their recovery, that's another avenue for them to come back and get services if they're struggling. So, so I know that I'm speaking from this perspective, but I think as a field, we need to figure out how to have consistent outcomes. And I know NATAP has done a lot in terms of outcomes collection and helping to support other treatment facilities with outcomes. But recovery housing also needs help and support in collecting outcomes and in being able to show both in story and in data that what they do is important and matters and that they're good at it. Right. So that gets at a little bit of all of that. So one is showing the importance of recovery housing. So I think all of us here would agree that recovery housing is really important. But then also ensuring that, unfortunately, with this vulnerable population, there have been bad actors. Right. And I think we can all agree that we've seen that. And because it's such a vulnerable population, I think it's why it's so important that we hold people accountable. So we have to have those metrics. The goal, the goal can't be to keep people with us for as long as possible for those dollars. That can't be the goal, right? And if you think about it, I was shocked by this metric when I heard it. Of all the people seeking treatment, the largest substance use providers have 1% of the market share at most. So there is plenty of work to go around. There is plenty of need to go around. We don't have to have this, sort of competitive thing. It can be all of us together fixing this because, for us as, we have locations across the country. And so for us to have like 1% of the market share of people who are seeking addiction treatment, that should tell you something about how big the need is. And so having that in mind and really partnering with each other and helping all of us, it's a lift as we go process. It's 1% of people seeking addiction treatment. Sorry, there's a question I saw.
Yeah, no, I was part of what we hope to do as well with the NAR affiliate is kind of a statewide, and we're calling it a coalition, right? Coalition of recovery residences, so that we can include not only people who are operating the recovery residences, but people who have been through or are in recovery residences and hopefully create this sort of community of practice and accountability. Right. So that, it's that almost like a rumor mill, right? Like if you have this coalition and we're meeting regularly, when we have communications and somebody's, being a bad actor, then that's going to get around a lot quicker if we have this sort of centralized organization. But
Yeah,
I appreciate the feedback.
Yeah, and if you're building a coalition, that is the perfect opportunity to have a common outcomes collection that you can all look at, right? We should all be transparent with our data because if we don't know that something's not working, we can't fix it. So it is the best time when you have that coalition to maybe work with some of the people who are here today on identifying specific measures of success and outcomes that would that your coalition would benefit from, and then everyone in that coalition commits to collecting that data and putting that together. I'm sure that there are people here that would be able to help with that too. So
as a researcher, I'm like, ooh, data.
yeah, absolutely. Yeah.
Thank you for that question, Patrick. John Major?
Certainly, Dr. No, excellent presentation. Thank you very much. I'm going to piggyback a little bit off that last comment and then just say two things. I think networking with others is, the step in the right direction. I've been in the field for over 30 years, like you, Dr. No, with clinical and the research experiences. And my Lord, there's been so much advancement in the last 3 decades, and it really warms my heart. But there's some bad practicing going on behalf, I think, of independent entrepreneurs and corporate greed. The commonality is greed. I think it's not putting the client's welfare first. And by networking with others, we realize who are the bozos and who are the superheroes. I now have been shifting from researching to doing consulting work, a lot of legal stuff. I was meeting with some researchers yesterday about a legal panel for the Oxford House World Conference coming up next weekend in DC. And it's crazy what's going on. We are not getting support. Recovery housing is losing support from the federal administration. And there are people who are emblazoned to say the most outrageous nonsense in public hearings that are highly discriminatory and apparently are getting away with it. So there's a big battle just on the recovery housing front. Saying that, I've been on the other side of the battle in legal matters representing, I guess, the evil empire. Say no to this treatment center wanting to come into a residential zone to operate. The reason is there is no justification, there is no therapeutic benefit that a recovery treatment must reside and operate within a residential setting. And drug rehabs, intermediate care facilities, all those things have special zonings. They don't need to be in a residence. Recovery housing definitely does. And there were cases where a district attorney in a Southwest state hired me because he was being sued by this small corporation who wanted to change the laws, who wanted to change the law that you cannot live in a recovery home for any more than 30 days. That's crazy. So with corporate greed, there are people not only wanting to go in and do bad practice and keep a revolving door style at the detriment of the people that they serve for their corporate profits, but it's going to have a ripple effect about changing policy. So what I wanted to say, two things. One, there's a difference between recovery residents, and that on the surface seems like recovery housing, but it's not. It's like and Betty Ford, I have utmost respect for as a professional treatment center. They do the good work in my experiences. So you have things like Betty Ford doing, there's 30 to 45 days, and we're going to transition you into a recovery home or a sober living home. And that's different, number one. Number two, about cultural sensitivity, Oxford House has networked with the Suquamish tribe in Washington. And that's a really good example of how they operate with the Oxford House model in a culturally sensitive way that meets the needs for the tribe. So I just want to throw those two things out and say thank you very much for an excellent presentation.
Yeah. Oh, thank you. And you raise really, really important points. I mean, corporate greed has not done us any favors. And there's a lot of money being injected into behavioral health in general. And the number of presentations that I've sat through with, kind of venture capitalist backed platforms, who, when we bring up any of the regulatory things, sometimes even HIPAA, it's like, oh yeah, we do HIPAA. Okay, what does that look like? What are you doing with that? And how well do you understand it? I think, and I don't know. I don't know that there's a simple solution to that. I think honestly, I think the solution is that we have to come side by side with venture capitalists so that we can guide it. Because I don't think we can't stop venture capitalists or that money from coming in, but being at the table when those conversations happen to really talk about the responsibility, the outcomes required, the regulations, the privacy and security concerns that there are. I think that is critically important.
No, absolutely. And not that I'm a big fan of National Alliance for Recovery Residents being the standard that everybody must adhere to get credentialing, because that's another can of worms that even Dave Sheridan agreed this should not be imposed on anyone. The point is, because of organizations like NAR and people and I-STARR, people getting together, I think we do influence. And I think that's why you have these corporate conglomerates coming by saying, oh, and we adhere to NAR and we ensure we have these things. So either directly or indirectly, I think coming together and working with them will steer them in the long run.
Yeah.
Thank you so much for that question. Vana Hernandez, you've been waiting.
Yes,
Hey,
hi
Sharon.
everybody. Thank you so much for the presentation. I'm really glad I'm on here. I typically come to these kind of presentations because I am a recovery home operator. And often on these types of presentations, there are not a lot of operators on them. So any opportunity I can get to advocate for recovery housing, I'm going to show up. So we are the second largest recovery home in the state of Illinois. We are state licensed and funded, so I know that we are very fortunate. We are a member of NAR, so I want to put those things out there up front. So we follow their standards, and of course, we are regulated by the state, so we have standards from the state that we have to follow as well. We have men and women, both programs, to separate facilities in the same location. We offer a plethora of recovery supports. We do everything to support our residents. And I heard questions at the beginning when the questions started about how do you get them those services? How do you keep them connected to treatment? And the answer is very strong partnerships. We have, because we do recovery housing, we understand that that is what we do and that's what we do well. We don't need to be everything to everybody. And if we try to, I think it waters down what the residents need. And that is our focus, right? And we are not clinical staff. We are not medical staff. We're not clinicians. So we're not working with them on treatment plans. We have treatment partners for that. We have 3 really strong partnerships with treatment providers, and they all offer different things. One is holistic care. They have primary care physicians. They have mental health services. They do MOUD, right? We have another one that is a dual diagnosis, co-occurring disorder. They do mental health and substance use, right? And then we have another one that is multiple paths to recovery. So they do treatment, they do smart recovery, they do yoga, acupuncture, right? So whatever the residents' needs are, that is where they go. We also have formal partnerships for primary care. A lot of them come to us and they haven't seen a doctor in years. So we make sure that they get to the doctor. We have workforce development partners. We have housing partners. And so that's how it works. And it works really well. All residents sign consent to release informations for all of the referrals that we provide to them. So we're able to communicate with those partners, with those providers. If they have a concern, they call us. We have a concern, we call them, but we make sure to stay out of their lanes. That is the only way that it can work, right? We're not going to tell them how to treat our residents. Whatever treatment plan you come up with, tell us how we can support you and the resident in making sure that they adhere to that plan, but we don't intervene. And our partners know as well that it's the same going our way. Don't tell us how to house our residents. Don't tell us how to run our program, right? Because they trust us. Part of that, building those partnerships, is we visit their facilities. And I mean, we want a tour, we want to sit down and talk with you, and we invite you to our facility. I don't think you really get it until you see how we operate, right? And so that's super important in developing those partnerships. So and the last thing I want to say is that we are larger, and I'm the executive director. I come from a corporate background. And so like you were saying, doctor, that it's still a business. Our business, we have a double bottom line. So we need to take care of people, right? But we also need to run a successful business in order to continue to help people. And part of that when I came on board was starting to collect data. We have a very robust data collection system. We work with researchers. We've done multiple research projects. We also have a low barrier recovery home, a harm reduction recovery home, and we've been working with a research team on that as well. So we have tons of data because that helps me advocate for recovery homes. So I'll be quiet with that.
Thank you so much and for sharing that with us. I think we have time for one more question, Dr. No, if that's okay. From
Yeah.
Kevin.
Yeah. Thank you, Vana, for that. Yeah. Mhm.
Hi there. I'm Kevin Wenzel, and I'm a psychologist. I work at Maryland Treatment Centers in Baltimore. And my question kind of goes back to the money thing, which seems to be a theme today. I So the treatment center I work at has about 95% of our patients on Maryland Medicaid. And there's a ton of interest in going to recovery residences. And we have two in our system of care. They're both fully funded by the state opioid response grants. And it has been just superb to have them as an option, as a resource, and to have that close integration. Cheryl was talking about like the recovery residence operators kind of giving a red flag, and Vaughn was talking about like knowing what your roles are. Like it's been a very helpful collaboration and thing we've figured out together, I guess, for the first time. But without the grant funding, most 95% of our patients would have a lot of trouble paying for recovery residences. And with the treatment bubble and the recovery residences bubble converging a little bit, overlapping a little bit, I'm just wondering about how the payer systems might overlap a little bit. I don't know much about how how things are with that. And I don't know if you or others know about reimbursement mechanisms for recovery residences or other ways to pay for it to move towards that goal of integration.
Mhm. Um, well, as I mentioned, the recovery housing component of Hazelden Betty Ford is not reimbursable by any insurer, which I think is unfortunate. I think is really unfortunate. But I wonder sometimes if there are ways to partner with housing authorities and where they're and aligning with other government agencies whose goal is to ensure stable housing. So, and I that is not my area of expertise. I have no idea. There's probably work being done there already, so I don't know. But I do think that in terms of the financial piece of it, we we all have to be really knowledgeable about that business side. And, I talk a lot to my team and we talk on our executive leadership team about having that diversity of revenue streams. Grants are one, different kinds of grants from different sources, philanthropy from different people, and then also whatever financial pieces that that you can put together. One of the things that I would love to see more of in this field is actually looking at some of the implementation scientists out there that are looking at financial models. And so I love the implementation scientists because they're so practical. And so there are implementation scientists out there that are now looking at how do you build a financially stable or a financial model that leads to stability and sustainability in organizations that historically have had a really tough time with that. So I think more work there could really help inform a lot of the work that we do here as well. So if you're an implementation scientist out there working on health economics and financial modeling, more of you, please.
There was one question, Dr. No, about what are some of the metrics folks are using for recovery housing? Because that's a separate system, right? From, opiate treatment outpatient programs or other outpatient programs. So what are some of the metrics people are using?
I think some of the metrics that I've seen, and someone might have better knowledge about this than me, but what I have seen is that there isn't like a specifically consistent thing that is measured across all or large swaths of recovery housing. But I think there are still outcomes around use and abstinence. I still see a lot of that. I see some well-being, sometimes some mental health measures. employee performance measures is sometimes part of that as well. There's also just general well-being. I'm looking at a couple of things here as well. Yeah, those are the ones that I've heard about most. So I don't know if anyone else out there has any other knowledge that they want to share, but those are the ones I've heard most consistently.
Mm-hmm. Okay. Well, great. Well, I think we're reaching time at this point. So I thank you so much for that wonderful presentation, Dr. No. And I would like to, at this point, move on and and tell you about some upcoming activities from the I-STARR project. So next month, we're going to feature Dr. Kevin Wenzel, who will be presenting on peer recovery support services for individuals and recovery residences on MOUD. In October, we'll hear from Dr. Bettina Hepner, who will be presenting on the intersection of recovery community centers and recovery housing. So unless it's otherwise advertised, the I-STARR webinars are held on the third Tuesday of the month from 11 to 12 for folks on the West Coast and from 2 to 3 for those on the East Coast. And you can register for any or all of the webinars that we have scheduled on the I-STARR website. You can also stay connected with the I-STARR project through our social media accounts, which are listed on this slide. While you are on the I-STARR website, you may also see information about the I-STARR training series. So the I-STARR training series consists of 12 webinars with separate training topics for both recovery housing operators and providers, as well as those interested in conducting research on recovery residences. So those who participate in all 12 webinars will receive a training certificate. And you can also be identified on the I-STARR website as someone who has completed the training. So at this point, because the training series, the live training series has ended, we can only track completion of the webinars if you register for the series and view the webinars in the I-STARR Learning Management System on the website. Okay, so if you have any questions about the training series or about how to complete it, please reach out to us. Next slide, please. So again, thank you for your time and attention. And it's really hard to stop these webinars, but I want to thank again Dr. No for an amazing webinar and everyone who's taking the time to attend this important webinar. And we hope to see everybody back on Tuesday, September 16th. So enjoy the rest of the day and the intervening month. And thank you again for being here. Take care. Thank you, Dr. No.